Okay, so now we get to actually talk about how we position the electrodes in order to get the current into the tissue that we want, as well as talking a little bit about some electrical safety. So when we are creating a current, a circuit of the e-stim unit and the body, we need to have at least two pads because we need the current to enter and we need the current to be able to leave. And that includes the patient in the circuit. And remember that we want those pads as tight to the skin surface as possible and in direct contact at that 90-degree angle as possible. So remember the cosine rule, the cosine law for that. We also mentioned that the skin, that outer layer of skin, is probably the biggest resistance that we have. And so we want to do whatever we can to lower that resistance. So one of the best things we can do is cleanse the skin. So we want to use soap and water, alcohol swab, something to clean the skin, get any oils off, any lotions off, any gels, any dirt, so that we have a nice clean surface to work for. Then you want to moisten the electrodes with either gel, a conductive gel, or a water. You can do a sponge that can go into underneath. So you'll see that with our big dispersive pads. We have a blue sponge that we put under that we get wet. That creates an environment to let the current flow. So water is a good conductor, so it's going to let the electrons flow. You can also potentially do what we call abrading the skin, which is gently scrubbing it with like an emery board. That's done more so when you're doing like diagnostic testing. So you might do that if you're getting like an EKG. But if someone's having poor conductance and we're not able to get the right current density that we want, so the amount of current, and we're having to turn up things too high, that's something we might want to try. As well as we want to shave hair from those areas. If they're going to be getting treatment on this spot over and over again for a multiple period of time, we want to shave the area that the electrodes are going to go, and that will help to reduce some of that resistance as well. Again, we want to make sure they're really secured to the skin. So when we talk about electrodes, we have kind of three different types that we have. We have metal ones, which are typically silver. Those are the most expensive. You'll usually need a sponge underneath those. We have our carbon silicone or our carbon rubber ones. And those carbon rubber ones are the black ones. You'll see those in our units. And they are reusable. Again, you can either use a gel, you can use water, or you could use a sponge as your conduction medium for that. But those would need to be secured on. They're usually not self-adhesive, and so you'd need an elastic strap or tape to hold those down. The self-adhesive ones are actually create the most resistance. So the carbon rubber ones give the least resistance. So that means it's also usually the most comfortable for the patient. They don't have to have intensities really high for us to get the target tissue that we want. They create only about 200 ohms of resistance, as long as we can get them flat, cosine law, right? As long as we can get them flat to the skin and they make good contact. The self-adhesive ones have the most resistance and are actually usually the most uncomfortable, but they're also usually the most convenient because they stick just by themselves. They already have the conductance gel, but they also usually have a finite lifespan. As they start to dry out or the gel actually starts to degrade, they're not going to be as effective. The cords, the wires can kind of pull out from them as the material stretches out. And so they're pretty expensive to replace, whereas the carbon rubber ones, as long as they don't crack, are usually fairly sustaining and can continue. If you are using one of the reusable ones, the carbon rubber ones or the carbon silicone ones, and you're using a gel, you want to make sure you put that gel all over the area, and then kind of rotate it to make sure that we get all of the material covered with the gel so that all of it is in contact with the electrode and the skin. Now the electrode size. Electrodes come in tons of different sizes, anything from as big as like 4x4 down to half-inch sizes. And size is inversely affects the current density. So the smaller the electrode, the more current density underneath it, which means the more sensation that the individual is going to feel and the more stimulation we're going to get under that. So larger electrodes have lower impedance than smaller ones. So the transmission happens smoother, and so you actually feel less current density under it. Smaller electrodes are going to require less current for the stimulation because they have high concentrated current density, but they can also be more uncomfortable. The size of the electrode is really going to depend on the target area. So you want to pick based on the body size, as well as, again, what's going to allow us to target the area the best. So when we talk about placing the pads, the electrode configuration, the closer together we have the pads, the more superficial the current flow is going to be. So my example of this is like a close basketball chest pass, right? So if you're going to do that crisp chest pass, you're fairly close to each other, you're going to have kind of a straight line. And so the current doesn't get down into the tissue as deep. If you go further apart from each other, we're going to drop that current deeper into the tissue. So think of it more as like a rainbow pass where we get that big arc in it. The problem is that if you get too far away, we create more parallel circuits, and so then we decrease our specificity. So you got to balance, you know if you want to target some deep tissue, we got to get further away, but we don't want to get so far away that we're not really specifying the tissue that we want to target anymore. Also, that allows potentially more ion flux because the area is so big that we can get more accommodation. Another thing we might want to target is using those stimulation points. So again, the trigger points, the motor points, or the acupuncture points. Those are going to give us easier current flow with not having to have as high of an intensity. When we talk about our point of stimulation, when we talk about being close together or far away, you always want at least one pad width between the pads. So depending on the size of your pad, you want at least one pad width between. If you can't get that, you might want to consider a different model for how we do and target that tissue. Different types of electrodes placements exist, and we're going to talk about those in a second. Another thing to go with is if you're dealing with a muscle fibers are 4 times more conductive when the current flows with the fibers than against the fibers. So if you're dealing with the quad and our injury is right here, we're going to want to put a pad proximal and a pad distal to follow the fibers of the quad. We would not want to go side to side because it has to go through all of that connective tissue through each one of those fibers in order to target the nerves and in order to get out the other side. So we increase our resistance this way. So always go with the muscle fibers. So next up, we're going to talk about the different ways we can align the pads. So the first one we have is what's called monopolar or unipolar. So remember that each electrode is considered a pole. And so when we talk about monopolar, it kind of gets confusing because you think that only means one pad. But we always need at least 2 pads to complete the circuit. And so what this does is it takes that idea of the current density based on size and manipulates that. And so you have unequally sized pads. So you have one pad that's smaller, which we call the active pad, and we have one pad that's larger, which is called the dispersive pad. And so the current density is felt more under that smaller pad than on the larger pad, and so we can target the tissue directly under that pad. Of our 3 setups that we're going to talk about, this actually has the deepest level of penetration. So remember we said frequency, the increased frequency can increase depth of penetration, as well as the type of setup that we have. So deepest penetration is in this monopolar setup. The active pad goes directly over the injury site, and the dispersive pad is placed over a large area somewhere else. The one place we wouldn't really want it is crossing the spine or over the abdomen. So we could put it up on the thigh if we were treating the ankle. We could put it up in the upper back on one side if we were treating the arm. things like that. So what this looks like, if this is our machine, we have one channel, so one cord that comes out of it, and then that's split into two to create the two entry points for the electrodes. In a monopolar setup, we would put a small pad on one and a larger pad on another. And that would be our setup. So we're coming out of one channel, so the electrons are going to run through the active pad, through the body to the dispersive pad, and back out into the machine. And what happens is, because this is so much smaller, we're going to have so much more current density that we're going to have so much more physiological effect under this pad than we will over in this pad. Okay, and that's the goal. So when we would set this up and start turning on the sensation, we'd want to make sure that they feel it more under the active pad than on the dispersive. Reasons we would use this, denervation of nerves, so when we need to target, so sometimes what we call probe. If you have a special machine that sets up that has a probe on it, which is essentially just a very tiny electrode, you can do what's called point stim, which is to directly target certain areas. And so you can do trigger points, you can use it for small isolated areas, you can do some migraine work, headache work. It's good for heel contusions. It's what we use most often for underwater. So what you can do is use one of our rubber carbon electrodes as the active. That goes into the water, so a tub of water with the person's foot or ankle, so something that's maybe irregularly shaped that we wouldn't be able to get really good contact on the pad, or maybe a smaller area that would be hard to get that contact for. The active pad can go in the water, the dispersive pad goes somewhere else in the body, and they feel the electricity, the stimulation through that active pad. We can do deep tissue work. This will also be what we use when we start talking about combo, which is a combination of ultrasound and e-stim. In that case, the ultrasound head itself becomes the active pad, and the dispersive pad you put somewhere else. A bipolar setup, so that was one, so monopolar, small active pad, large dispersive. A bipolar setup, you have two equally sized pads, and you want to encase the injured area. So if the injury is in the middle of the quad, we would have one pad proximal and one pad distal. It has the least depth of penetration of all the configurations. And again, you control that a little bit more. Are your pads close together? That's going to be more superficial. Are they further apart? That's going to be more deep. And the current should be felt in between the two pads. So felt in both pads equally as well as in between. And again, because that target tissue is going to be in the middle. So our experience for this is, again, we have that one channel, and now we have two equally sized pads that are both active. So we would put the target tissue in the middle, but they have equally sized pads for the bipolar electrode configuration. The final one we have is bifurcated, which is where we can actually split one of those channels, or I should say the final of these three. We'll have one more, but we can split one side of the channel, one pole, into two or more pads with what we call a splitter. And so in this case, we have a dispersive pad, and then we split the active pad in order to encase the area. And this is our middle depth. So monopolar is the deepest, then bifurcated, then our bipolar, where we have the two equally sized ones. So it acts like a monopolar setup. As long as the area of the dispersive pad is larger than the combined area of the active pads. So we always want our dispersive pad to be about 2.5 times larger, at least, than our active pad in a monopolar setup. So in bifurcated, if we're going to split that into two pads, those two pads added together in size need to still be about 2.5 times smaller than the dispersive pad itself. So what's that look like? Again, we still have one channel coming out of the machine, and then the two leads. The one goes to the dispersive pad, and then we would put a splitter on, which would allow us to attach two here. Now, why would we use this? So let's say we have two areas of injury. Maybe an ankle sprain, right? Where we have pain on the medial side and the lateral side. We could split the active pad and have the dispersive up on like the hamstring, okay? Or you want to encase the area. So maybe you have pain anterior and posterior on the wrist, and then you could put the dispersive pad somewhere up on the arm or on the back of the shoulder. And that way you could target pain on both sides. So that's usually what we would use the active